All right. Being Tuesday, April 19th, 6:30, I'd like to open the Special Committee on Opioid Epidemic. Please rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Please remain standing for a moment of silence for our men and women in harm's way. Thank you. Please be seated. Ms. Semino, could we have the roll call, please?
Braintree Town Council Special Committee on the Opioid Epidemic, meeting of Tuesday, April 19th, 2016. Councillor Koukouris.
Here.
Councillor Clifford.
Here.
Councillor Hume.
Here.
Councillor Owens.
Here.
And Councillor Powers will be attending late.
Yeah, he's on his way. Thank you. We're going to skip over the minutes for now until we can get those compiled. We know old business. I have a couple of things I'd just like to read into the record before we start our discussion with the Braintree Fire Department and the Braintree EMS Brewster Ambulance. I received a letter from the mayor today, and it reads as follows. As we discussed, I want to offer some thoughts to you and to your committee as the council engages in a review of our opioid challenge here in Braintree. As you are well aware, the Braintree Community Partnership began its work in 2011, and through joining with the Braintree Alliance for Safe and Healthy Youth, BASHI, and more recently the Braintree Youth Center, we have created a cohesive educational and awareness program utilizing all of our resources through our police, fire, health, and school departments. Additionally, working with our parents, as well our regional partners in the District Attorney Morrissey and Norfolk County Sheriff Bellotti, and our state officials and Senator John Keenan and Representative Cusack, we have established a strong line of communication at the regional and state level. Bob Folks from Congressman Lynch's office has attended many meetings of our partnership as well, which has broadened our outreach efforts. All of this is being done to raise the level of program awareness, as well continuing our educational efforts in support of those addicted and their families who have been significantly affected by this opioid epidemic. Our work has been successful in saving lives. Since March 2014, there have been approximately 300 cases of drug overdoses with 106 uses of Narcan and 99 lives saved. We are currently offering Narcan in our schools through our school nurses. Most recently, the partnership offered another educational program which was attended by more than 170 people. It was a very impactful evening, which underlined that Braintree is serious about addressing this epidemic in a meaningful way. In addition to our regional partners, we have been able to partner with Impact Quincy and other towns on securing funding that support our current efforts. We will continue to seek additional monies, believing that a regional approach will make a lasting impact for all of our communities. An area of this issue that we are now focusing on is the subject of recovery, specifically how we can position ourselves to work with area hospitals to provide beds for our people in need. I am currently exploring a number of ways that we, through the partnership and with your efforts, to discover an approach that can be a lifesaver for those who need our help. The partnership is in agreement with the Town Council on the MMA pamphlet, An Obligation to Lead. And I would stress that we are accomplishing many of the items that are contained in their brochure. The department heads that will be offering commentary to review will note the many steps that we are performing regularly. Their work in the efforts of our many employees in the health and public safety field, as well as our emergency medical services, should be appreciated and applauded. It is difficult work and they are doing every day. Your attention to this matter and your support of my request for an additional $25,000 in the supplemental budget is greatly appreciated by all who care and who will never relent on this opiate epidemic, and that is signed very truly yours, Mayor Joseph C. Sullivan. And that was sent down to me today, and I want to thank the mayor for that letter outlining some of the accomplishments and the work that's been done by the partnership. I'd also just like to read into the record as well a piece of information that came to us from Attorney Bob Hines. And there is a program out there for free legal assistance for someone that needs to section an individual family member, and basically they will offer free legal help to anyone that feels that they need to take this legal action against a loved one so that they can get them the help they need. And there's a phone number here I'm going to read. It's 844-843-6221, or they can go on helpus@massbar.org. And this particular offer that Attorney Hanez has given to us is available to anyone, and it's free. So when people don't have any idea who to turn to for legal help with a loved one that needs to be placed in care, they can call this number, or they can call the council office and get this information. Okay? And what we're going to try to do is, as we progress through these meetings, as we receive valuable information, we're going to let the public know about it, and we're going to continue to let the public know about it at each meeting so that the message is clear. And as we go through and collect information from each department for our report, which will be finalized and pretty much given to the partnership, I just want to make sure that anytime something like this comes along to any member here, that we have the opportunity to make it public immediately. Okay. And I thank you for your time. Councilor Clifford wanted to say something before we brought up our guests tonight. Councilor Clifford.
Thank you, Mr. Chairman. Because we are on BCAM and we have people watching at home, I think it's important that we start every meeting by letting them know what it is we are doing, how we're doing it, and what will be produced from it. So the mission of this committee, which is based on an obligation to lead that the MMA distributed in January. And
Can I just talk for 1 second? Just so that everyone out there understands, the MMA stands for Mass Municipal Association, which is an association that pretty much all 351 cities and towns belong to, and they provide us with very valuable networking information, et cetera. Go ahead, Mr. Clifford.
yep, thank you for clarifying that.
No problem.
Sometimes there are multitudes of acronyms that abound around this whole thing called the war against opiate abuse and addiction. So if we do use acronyms or abbreviations, stop us. To go forward again, the mission is specifically focusing on 10 areas of opportunity that the MMA has defined, and asking all the 351 municipalities to take a good hard look at those 10 opportunity areas. So that's the scope and the width of what we're doing. So the mission itself reads, our mission is to assist, to seek, to expedite, and to recommend prevention, whether it be deterrent or education, and public safety initiatives, and identify potential funding gaps There's lots of activity that could be going on that if they were funded, we could move in those areas. So part of this mission is to identify any funding gaps that may exist to implement local actions and initiatives, including the rising resource demands of our police, our EMS, and our fire department specifically. All objectives, all new or adopted local initiatives will have clear, attainable goals and objectives that will be tracked, measured, and reported on. So the scope of this is that this special committee will facilitate meetings with municipal leaders, both here and outside of Braintree, that have demonstrated best practices. As we go through this, there'll be some best practices that we'll bring forward that maybe the fire department, maybe the police department, maybe the schools can adopt. Because other communities are using them. If they can't be adapted or adopted, then that's a different story. And included in those department heads or departments and organizations we'll bring forward include the schools, the health department, Braintree Youth Center, Braintree Community Partnership, police, the fire, the school leaders, health professional, legislative leaders, municipal solicitors, school nurses, veterans groups and agents, recovery homes, and town recreational programs, sheriff's office, youth services, and MMA task force, and including clergy. So it's a broad number of folks that we're bringing together. There's lots of good work that's being done, but I'm sure there's some gaps. And so we're looking to see whether we can identify those gaps and come up with funding so that those gaps can be covered. Thank you. With that said, there's I call them factoids. I'd like to share, and I hope there's a little shock and awe, especially for folks that might be listening at home, when they hear some of these factoids that I'll start each meeting with, just to plant some seeds or to help educate. Because part of this discussion that we're having is education as well with parents and the community. And now that it's being televised, we hope that we'll be able to grab onto more people and broaden the understanding and the information that's out there. So, a few statistics on opiate addiction and recovery. Opioid addiction costs Americans over $484 billion annually. Opioid use and addiction is linked to at least 50% of major crimes in the United States. The United States consumes 80% of all opioids manufactured. $605,000. Now this is dated, because this is dated 2005, so this information will be a little dated, this point. 605 Americans aged 12 and older had abused heroin at least once in the year prior to being surveyed. 90% of all opiate addicts will relapse within the first year after completing a traditional treatment program. The number of people who have used prescription opiates for non-medical reasons, at least once, 50 million. So I'll just leave those little factoids out there, hope that they resonate, particularly with the folks at home that are listening, because this is a serious problems. Everybody in this room is aware of it, but those that are at home can use some more information. Thank you.
Thank you, Counselor. So at this point, our goal is to listen to information provided by Fire and Brewster Ambulance in regards to Braintree specific and any other data outside of Braintree that you might have in regards to this current epidemic that we want to address. So we have this this table set up, and I don't know whether you want to have fire come up first, or it's something you guys want to do as a group, or however you want to do it, whatever. Whoever wants to come up first, come on up and have a seat. Okay, thank you. We have, if you guys want to just, you might want to share the mic if you need to. I want to thank you folks for taking the time and coming out tonight. Thank you. So you were given a letter, and that letter basically was pretty much driven by the Mass Municipal Association's their 10 different items that they wanted us to address. The 10 items that were addressed by a small committee made up of municipal leaders, and they come up with these this obligation to lead in these 10 items. So I know that you guys have received that letter, so I would ask you to present whatever you think is significant. Thank you. Oh, yeah. If you want to just first introduce everybody that we have.
I'm Chief Jim O'Brien, Braintree Fire Department. This is Chris DeBona from Brewster Ambulance, Lieutenant Kevin McAleese from the Braintree Fire Department. We're basically here to answer any questions you may have for us regarding any literature you have in front of you.
All right, if you wanted to just give like I mean, you guys had given us a presentation before. If you wanted to just give us any of the data, I know we've already had you come before us in regards to the data. I just happened not to be at that meeting, so I missed a little bit of that. But
well, one thing I can tell you is that one fact we left out at the last meeting was the fact that it's in the mayor's letter. I had informed him of these numbers this morning. The overdose number is actually 300. So when you consider the numbers that you have in front of you, the 99 reversals versus the 7 deaths, 2/3 of the overdoses didn't require Narcan. Now that doesn't diminish the fact that it was an overdose. It just means that it was less severe. They were either treated at the scene or transported without the use of Narcan.
okay. Does anyone have any questions at this point? Councilor Owens?
Thank you, Mr. Chairman. Of those 300, Chief Lieutenant Christopher, thank you for being here. Of those 300, how many were opioid related? Do you have a number on that?
Yeah, so it's difficult to quantify because a lot of these folks are polysubstance. So the way we run our numbers are substance abuse or overdose, and that could be a litany of things. It could be benzodiazepines, it could be opiates, it could be alcohol, marijuana. So those are very difficult to drill down. When you find a reversal agent such as Narcan that's provided and it works, then they get thrown into an opiate category, but it still doesn't mean that other things are on board with the polysubstance piece. So to kind of echo what the chief said, in running our numbers on the ambulance end, we are close to 300 substance abuse and overdose responses, and that's from 2015 and now early 2016. Again, on the EMS end, we found that we had 47 deployments of Narcan. That's just on the EMS end, not including police and fire. So that's what we have on our record, but Kevin will have the full scope of those deployments there. With that being said, I really feel that we're making some progress here, and I know I'm thinking a little bit outside the box, and I might be on a little bit of an island with this, but the interaction between the community, police, fire, EMS, schools, hospitals, pharmacies, local and federal government, as well as the court systems, is a tremendous undertaking. Now there needs to be a significant buy-in from the individuals to make that change. This is it's pretty clear that everyone is engaged with this piece of it, and that support has been very well established. What we're doing on our end is some recent broadcasts as well. We recently had a piece on 60 Minutes that was released. That was a national broadcast, and CBS Local was doing some broadcasts locally in regards to that. So with that being said, I really feel like we're making some progress. Everybody's engaged, everybody's in tune with this piece, but we still have some work to do. And everybody's willing to do it. That's our mission, is to provide the treatment and the help that these folks need. But I really agree with you folks that the recovery is our next phase of that. To give you a little bit of calculations, out of those close to 300 calls, the man hours put into that, and this kind of goes into play with what you're looking at as far as that assistance, 430 minutes were spent during these calls of substance abuse and overdose, which equates to 340 man hours or 14 total days of 2015 and early 2016. So a tremendous amount, and that's just on the EMS end. Now you also lump in the fire department, the police department, and the hospital piece to it. That will clearly add up to the billions, Mr. Clifford, that you alluded to. It's a tremendous amount of money that's put into this, and a tremendous amount of effort. With that being said, folks aren't complaining when they do these calls. It takes a lot of resources to do them.
Thank you. Anything further? Councilor Hume?
Thank you, Mr. Chairman. Okay, couple of questions. In order for you to effectively do your job, or to better do your job, I guess, in terms of, the opioid epidemic, what do you need or what do you want, whether it be funding, more staff, more training, more supplies? If you could have anything, what would that be to combat this and to help you save more lives, I guess?
I'm sure the three of us have three different answers, or three answers that may, assist this. But for me, it's more of the early education. That's the piece that I'd like to focus on. I think the police do a fantastic job in schools. I attended a meeting last week at Braintree High School with school committee member Ringus, and basically the fire department's going to get a little bit more involved in the schools as well with the education. So we're looking at different ways to do that and integrate ourselves into the school system.
So in order for you to do that, can you do that with the existing resources you have right now?
Yes, I believe so.
Okay.
I think as Chris said, everybody that he mentioned, including yourselves, we're in this to win it. So, it's not money driven on anybody's part. I think that, volunteerism has to step up and do a little bit. So I myself am more than willing to go into the schools. I'm sure Kevin, I'm going to throw him under the bus here, but Kevin's done yeoman's work for the Braintree Fire Department, and he continues to do a great job, so I'm sure he would be willing to help me with that. So, and that's my main focus, or one of my main focuses. Obviously there's a lot to focus on, there's many aspects of this, but for me, that's my main piece.
Okay. How about EMS?
What I would like to see, and to complement where the chief's going with this, is historically in schools, especially in the high school setting, we've always done mock accidents, right? So you have a mock accident in front of the school, and everybody, the drama class gets involved, and it's this big to-do, and it impacts drunk driving or drug driving, during the high school period. I'd like to take that spin on things and turn it into a mock overdose, where folks are engaged in their school. There's an overdose that happens either in the cafeteria or in the hallway, and it gets away from that graphic dynamics of having the tow company bring in a car that sets outside the school and you got to get everybody outside there. Is do an initiative more along those lines for the impact, and really bring in the gear and the mannequins associated with that, and let them know that it may be one of their friends. And really I hate to say this, but the primal activity that goes into resuscitation of these folks It's very primitive, it's very invasive as to what happens, and maybe that will make an impact, that visual piece of it, just like the accident scenes have over the years for the mock crashes. I think it'll be a little bit of an undertaking, possibly with the school systems and the parenting that, that may have a say in what their, kids see or don't see. But that's clearly made an impact over the years as those mock crashes, and maybe some kids, walked away with a different thought process going into prom seasons and things like that.
Can I? Okay, so you said it would be an undertaking in terms of, have you done this in other districts?
No, so we do simulation with our clinical providers all the time. So we simulate cardiac arrests, overdoses, any sort of medical conditions, trauma conditions. This isn't foreign to us at all.
Okay.
This would be more of a demonstration that's in a public forum for folks to see. And it can be done on a simulator, so there's not actually a live patient that's involved. You could probably have, somebody collapse so they know it's a friend of theirs. Make them disappear out of the room, replace it with a mannequin, and anything can be done on this mannequin as far as resuscitation. So they can see CPR in progress, airways being introduced, medications being provided. And whether you spin that into a positive outcome or a negative outcome, that's entirely, based on what you're looking to deliver there.
Okay. Would your best audience be the schools, or do you want to expand it from there? Maybe do a town event here, potentially?
I guess sky's the limit. I don't know what you'd recommend. I always thought that the crash impact piece would be great in the schools. I think those folks come out of it. There's a number of schools in Braintree. We don't have a problem scheduling that out. But I think the impact would be greater. And maybe in the larger schools, you can do it in different areas at different times so that you get the most bang for your buck. The equipment's there, the personnel's there. I don't know how that schedule would work. I think the schools would be I don't know if you disagree, it might be the best impact. And you cover a wide range of school-age kids.
Okay. Can I continue? Okay. Lieutenant McAleese, anything to add from what Chief O'Brien said in terms of?
I agree with the chief. I would just like to see it go to adult education. If you had asked, John or Jane Doe on the street, if Percocet or Vicodin was related to heroin, they would say no. So when Jane and John take Joey to the dentist and he comes home with 30 Vicodin, Joey knows what Vicodin is related to, and so doesn't Joey's friends. So if we step up the education to the adults and focus on the adults while the kids are getting it in the schools, and I think that would be a great combination to move forward. Because the way the world spins now is, nobody has any time. Nobody sits down to have dinner, to talk about what's taking what and where's going who. So I would like to see the adult education.
Okay.
Could I add something,
Yeah.
Council Shannon?
Oh, well, yeah.
At that meeting last week at Braintree High, there seemed to be a concern with how it would fit into the curriculum. Would it interfere with the curriculum? And, from my point of view, this can't be a one-shot deal. This has to be an ongoing educational tool. I mean, you can't do it one time and forget about it. So I guess part of the problem there for the schools would be how they would fit that in to their regular days.
Okay. I agree with both of you on both points. The educational piece from a parent's perspective, I've heard from so many people, the doctor prescribed me this, said take so much every day, and they take it without knowing that maybe it might not be good for me, or I shouldn't be taking it for 10 days if I'm feeling better after a day. So I completely agree with you on that, Lieutenant McAleese, and also Chief O'Brien. I remember when the partnership brought in Chris Herron years ago, and I had the opportunity to go to that, and I was blown away by his presentation. And I remember someone telling me, bringing up in a conversation a couple years after that it was great then, but to your point, what you just said, it has to keep being told to these kids because they leave and they were stunned. I mean, people were crying in the audience. It was made a huge impact. But yeah, the conversation and the education can't stop, so I completely agree with you. And another question, if I can, Mr. Chairman. So within both your departments, is everybody trained in this? Is there anybody, I know Lieutenant McAleese, you recently went on special training. Does your whole department, both your departments, have that opportunity to go to this training or any conferences like that? Or how does that work? And if not, why?
On the EMS end, we're getting a steady diet of this through our medical community partnerships, through our hospitals, our medical directors, different publications. So although some of the meetings, we're involved in all the coalitions locally and with the municipalities, but for some of the travel and 4-day events, it seems to be outside of some of the education realm with us. But we keep very well current with the trendings, the patterns, some of the progress that's out there. And like I've said before, we've got a lot of buy-in from the folks that are engaged. Also, the pharmacies, we saw an initial spike in the price of Narcan. That got quelled pretty quickly. So now we're back on a level playing field with the pharmacology. It's not that price gouging we were seeing there. But we do have those opportunities. They come up very, very frequently. But you can be engaged in this 24/7, if you want to. There's that much opportunity for progress here.
On the fire department side, Lieutenant McAleese is the first one from the Braintree Fire Department to attend anything like this convention. Obviously, would like to see more of it. That's budget driven. I'm sure I can come up with something in my budget to send Kevin and Fred Viola, our other medical coordinator, to more of these, because Kevin got a lot out of it and brought a lot of it back to the fire department. And as one of our trainers, he passes that along to the rest of the firefighters.
Okay, and one final question, if I could, Mr. Chairman, thank you. Just for the people at home, and because our meetings are now being televised, can you, any of you, explain what Narcan is and how each of your departments get it, whether it's through a budget line item or a grant or other means?
Good hit.
Thank you for that. So Narcan, or naloxone, has been around for a number of years. We've had it on the ambulance for probably close to 40 years now, but we haven't seen the increased use of it. It was an occasional use, but now it is a very aggressive use of the Narcan. It's probably our third in line of medications that we use on the ambulance daily. The first two medications are cardiac resuscitative medications, and they're given in multiple volumes, so that's why you see the volumes higher. Essentially what Narcan does is it blocks the receptors of the opiate, so that folks don't, for lack of a better term, have that not breathing appearance. It blocks the receptors, and there's about a 20-minute reversal on that. It is a drug that gets metabolized, so after 20 minutes, folks start to get back into that feeling that they were initially feeling. So it bridges the gap of overdose and breathing to support. But it is definitely not the end all, and you can't just provide the Narcan and expect folks to become better. They will get back into an overdose state within 20 minutes or so. Again, if it just clears the opiates for that period, if there was a polysubstance piece that's in place with benzodiazepines, alcohol, marijuana, or whatever it may be, those chemicals will then take over.
Go ahead.
And how is yours funded? Is it through your own budget, how you receive Narcan? Because I believe there's grants for, did you get the grant through fire?
The fire got the grant, and the fire does a one-to-one swap with the hospital. So if I use one dose on a patient X, I go to the hospital pharmacy and swap it out.
Okay.
For us on the ambulance end, we're a for-profit private entity, so we pay for our pharmacology.
Okay. Thank you very much.
Thank you, Councilor. Councilor Clifford?
Thank you, Mr. Chairman. Chris, At one of the coalition meetings the other day, both you and Lieutenant McAleese attended and shared some very interesting information and statistics on overdoses. Those overdoses, would you like to go over those again so the people at home can hear them? Are you prepared to do that?
Do you have the numbers? Lieutenant McAleese has those numbers.
And while Lieutenant is pulling those out, while he's doing that, if we could go through some of the cost components. Narcon is what, $800, $600? But under the grant, it's how much?
Yeah, so there's a couple different options available. The option consistently used is an intranasal approach where the medication is sprayed to the individual. That cost is about $12 to $20 a dose. There are now folks jumping into the market, a little bit of a spin-off of the EpiPen for allergic reactions. So they have an automated device, which is a needle that talks to you through the process. With that technology comes expense, and those doses are about $300 to $400 for the device because of the automated approach, the auto-injector, and things of that nature. So there's a very wide fluctuation of what is out there. There's another device being developed by a physician, I believe in Maryland. Correct me if I'm wrong with saying.
That's correct, Maryland.
And what it is, it's a nasal application for a mist that's sprayed to the individual. It's in a lower cost device, which is not automated, it doesn't talk to you, and it's about $50 a dose. And what this does is it takes the assembly away from our conventional intranasal approach, where you have to connect the vial of medication to an introducer, you have to screw it together and make sure that it's delivered appropriately. This gentleman took the legwork out of it because in a stressful time, it's difficult to put these devices together if you're not used to doing so. There's a little bit of a muscle memory that goes into place. If it's not assembled the right way, the medication won't be distributed. So you're looking at an area from $20 to $400, depending on the automaticity of the device. Unfortunately, like any pharmacology, it expires. So if it's stockpiled, if it's kept on shelves, it will eventually need to be replaced at whatever expense it will be at that time.
And Chief, how many do we carry on hand? What would you say the cost components of a call is when you get dispatched for an overdose? What goes into a call?
If we could just walk through specifically, you find someone that is overdosed and, you try to, you make sure that they are overdosed, and at that point, you start to administer Narcan in the process, and I know there's some breathing and things like that that go into it. Maybe you can just walk the public through how you handle someone that has overdosed on an opioid from start to finish. Brewster would be, yeah, Chris would be great.
I have not.
Whoever wants it.
I do.
Lieutenant McAleese has a dose of Narcan on him. He can show you that piece, but I can tell you that the initial response will come into the call center. There's emergency medical dispatching that is handled to provide support as first responders are en route to the scene. You will get a complement of police, fire, and EMS response. In the town of Braintree, you'll get 2 paramedics that respond to the scene. Normal interaction with the patient is dependent on their severity of overdose. So that could be anything as performing CPR or just rescue breathing for the patient while the device is assembled to deliver to the patient. Along with that comes into play a litany of medical devices that are applied, cardiac monitors, there's blood glucose that's checked, there's IVs that are established, there's oxygen that's provided, hemodynamics are acquired as far as blood pressure and pulse rates, and then just generally monitoring the patient. As the medications assembled or provided, you always look for the patient response to that. Some may require another dose of the medication. We may find that the patient is not overdosed on an opiate, and maybe it's just purely benzodiazepine, so this medication is not attacking that. So different conventional methods of support are provided to that patient. There's extrication that takes place from either the home, a vehicle, or a public place. And then there's continued treatment, transport to the hospital. There's follow-up with documentation, reporting, and charting. So there's a tremendous amount of man-hours, documentation, replenishment of supplies, and reporting values, as well as meetings and things like that.
So Chris, specifically, when someone is in an overdose from an opioid,
Yes.
it basically shuts down nervous system, breathing, things of that nature. So at that point, medically, when you're doing their blood pressure is extremely low, I would assume at that point. And I mean, the heart rate is reduced. So when you give them a dose of the Narcan, whether it's injected, whether it's nasal, most of the times when you get on the scene, I mean, if police are there first or fire's there first, whoever gets there first is going to apply the Narcan. So normally, most of the reports I see, it's multiple doses of Narcan.
Yeah.
I don't think I've ever seen one where there was one dose that, I would say that's probably a 10% chance that it's one dose that revives somebody.
Yeah, I can answer that. There's been a stockpile of pharmacology that was released through grant funding that is not your standard 2 milligram introduction of Narcan. So the auto injectors were pre-filled with 0.4 milligrams of Narcan, which required multiple doses to get you up to the standard 2 milligram dosing. With that being said, it was grant money. It was devices that were released, but they were released in large numbers, so it would accommodate the multiple doses that needed to be given to the patient. To answer your first question, what happens with the patient during an overdose is they stop breathing. Everything after that comes secondary. So you get the lower heart rate, you get the lower blood pressure, and they progress into a cardiac arrest state. If you simply rescue breathe for a person who is overdosed, you will help them through the event. So the Narcan, as much as it saves lives and it increases your drive to breathe, can simply be offset by just breathing for a patient, whether that's through a medical device or rescue breathing like you would normally learn in CPR. That will bridge the gap of that patient not breathing, and their blood pressure will not drop, and their heart rate will not drop. So the Narcan, as it occupies those receptors, increases the drive to breathe, and they're good to go.
Excellent.
Yeah, thank you. So let me go back, Chris, to the meeting the other day before Lieutenant McElvey fills us in on the information as well. There was a comment that was made that said that there are resources are being stressed, and there's cost associated with that stress because of the increased number of calls that continue to come in and are growing exponentially. There are grants out there, and what we're trying to do is understand where we can help in terms of going after those grants. When you mentioned the word stressed and resources being stressed, there was a direct connect there. That there's a $125,000 a year grant that Weymouth has and Quincy has, and it's for 10 years. It's $1.25 million. It's a drug-free communities grant. So if we can come to understand where the stresses are within the organizations, whether they be fire, police, EMS, schools. I had a brief discussion, albeit, back in December with the superintendent of schools, when we were specifically talking about curriculum change, because not since 1999 has the health and wellness framework curriculum for schools in Massachusetts been changed. Now, schools are given an awful lot of flexibility. But even though they're given a lot of flexibility, in other words, Chief, you mentioned, what do they remove from the curriculum to add in a drug component? That's stuff that in December we talked about, and Mr. Ringus is chairing that committee. But there's a lot of flexibility. However, the superintendent mentioned to me those are resources that are needed in order to do that. So if we had $125,000 for 10 years, we have some resource to get that done. So that's where we're driving. We're driving from, let us understand where the gaps are. And then let us go, you know what? We should already have that $125,000 grant. Weymouth has it. Quincy has it.
Well, to address your statement, Council Clifford, again, to rehash what I said originally, my opinion, for $125,000 a year, you have to focus on more or less one aspect of it, because it's not a lot of money. It really isn't. So that $125,000, in my eyes, should be going towards the education and prevention of this. The recovery, the aftercare, things like that are a lot more expensive than $125,000. I think we all know that.
Well, let me not just focus on the 125. The point is that there are numerous grants out there. There's another one that the federal government has just released, and Massachusetts under Governor Baker has released $85,000 a year for 5 years. So there are a number of grants out there. If we go and we get them, then we can help support some of these things that we need to get done.
Absolutely. I can only go under the assumption of that 125, though, and what my opinion is of where it should go and how far it will go.
Yeah. All right.
Okay, Councilor Powers just had something to say, and then we'll go to Lieutenant Matt, please.
Thank you, Mr. Chairman. Thank you all for being here this evening. If you could, so if an individual is basically brought back through the use of Narcan, what role could first responders play? There's been a lot of talk of recovery. What roles can first responders play in the recovery or the beginning steps of recovery for an individual, if any? The process doesn't stop when we're trying to get someone to recover from the use of Narcan and they're brought back, thankfully. Is there any role that first responders can play in recovery of an individual?
Chief, I would say that in Quincy, someone had mentioned to us that there was a one-page sheet that is given out to the family, for example, and it has all of the information in regards to recovery, places that they can call for assistance to try to help that person. So I would say that in that question, is that something that, you could reach out to Quincy and look at what they have and maybe tailor
Absolutely.
something like that?
We can piggyback that. That's
What's that?
We can piggyback that idea. That's not a big deal to hand somebody a piece of paper with some important information on it. Beyond that, honestly,
There's only so much that we can do. You might have just saw that Boston Police had started their, opiate task force, 5-man car, where they go out after the fact. And maybe that is a fit for Braintree, maybe it's not. I don't know if the police are trying that or not. It's going to be one of those challenges. And you could do the informational booklet in the public service announcements like Quincy Fire did. All the power. That would be great. Will it get through to them? Would the, information get passed on? We used to leave the business cards for the man of health, and we didn't get any hits on it. So, it's,
If I could follow up, Chief, I know you live in town. Lieutenant, I know you live in town. I think if there's a way that we could use our personal local connection on behalf of our first responders, I know that there are many folks in the Brewster ambulance family that are local If there's a way that we could use the local, I mean, a firefighter might know a family that, is dealing with an individual that had just overdosed, or a police officer, if there's that personal connection that we can use to start the process and steer the family in the right way, I think it would be beneficial. I mean, I know that South Shore Hospital, I'm sure, has counselors and folks on their staff to assist families and individuals that overdose. But if there's a way for us, for a town of 36,000 people, it is still a pretty tight-knit town. And folks know each other, folks know neighbors, folks have friends, folks who went to school with each other.
I believe South Shore Hospital just hired a after overdose advocate, if I'm speaking incorrectly.
No, that's correct.
Okay. I think that was only a few weeks ago, though. As far as what we can do, it's a great idea. It really is, and I fully endorse it. I'm just not sure where that would fall under the HIPAA laws.
Sure.
Some families, still, they don't want to see us. They don't want to acknowledge it. And for us to extend is one thing, for them to accept is another.
Mm-hmm.
We can't force ourselves on them, much like the police can't. We'll make every effort to do that and to get them the help they need. But it's something that I guess would have to be looked at, and maybe Chris, I'm going to throw you under the bus here. Maybe you could talk a little bit more on that.
Yeah, I think it's important to recognize the individuals that are affected here. If we look back at Mr. Clifford's numbers, a lot of these are prescription or legalized, delivery of medications that are out there. So on the EMS end, what we look at is not only the user of the opiates illegally, but we also look to cover the kids, and we look to cover the elderly. So what happens with these folks with prescribed medications is children get into these medications accidentally, and they may need a reversal agent to assist them. And the elderly, if they're forgetful, they may double dose on their medications or their fentanyl patch or whatever it may be. So you really want to cover all categories of the individual. What I'd like to see is maybe some forecasting or some intelligence within the community of, retrospective hotspots that we normally see, and impact those areas. And it may be pediatric areas, it may be high illegal drug user areas, or it may be the elderly complexes, to provide them some education, just to say, manage your medications appropriately, let your family members handling, distributing your medications or whatever it may be. I think that might be a great opportunity. A lot of us focus on the illegal user, but if we look at those numbers that Mr. Clifford said, these are prescription legal releases that are out there that folks get into, they forget to, they double dose, or it's an accidental piece. I think we should incorporate all individuals under this umbrella. It may have a more significant impact.
If I could just end with a comment, it's great that we're expanding the access to Narcan because it's saving lives, but I think we all want to get to a point where we don't have to use it anymore, because that would show that we are being effective in educating folks about opioid abuse. And that starts with education and prevention, like you had mentioned. It starts with parents, it starts with kids. And I think that is a major charge of this special committee, is to find ways to find funding, find ways to support programs that will increase the education and the prevention, so that when we're seeing a decrease in the use of Narcan, it correlates to a decrease in the amount of opioid overdoses that we are responding to. And hopefully someday, we can put the folks that make Narcan out of business because we won't need it anymore, but that is obviously a dream and a long-term goal that is going to be very hard to achieve, but I think it's something that I think all of us want to see happen someday. Thank you, Mr. Chairman.
Thank you, Councilor. And
Thank you, Mr.
Councilor Owens just wanted to say something before we have Lieutenant McAleese give us that update.
Thank
Councilor?
you, Mr. Chairman. I do have a few questions. I talked in the first meeting about the three different areas of this problem, which are supply, which really starts with the pharmaceutical companies, and of course the legal side of heroin as well. Then there's education and prevention, and harm reduction and recovery. And all of the attention from the federal side has been focused on harm reduction and recovery. And, when we look at this situation in totality, it seems that harm reduction is getting the most attention, which is important because that's what immediately saves lives and brings people back to life. But it also, I think we're really lacking in the area of education prevention. And, Kevin, Lieutenant McAleese, you brought up a great point about educating parents and adults, and that's something I've been a long-time advocate of. That's something we seriously have to do because, parents are typically the first suppliers of opiates to a child, and they don't know what they're distributing. In your opinions, what are some ways or venues to reach parents or to reach adults to educate them about what an opiate is and what the potential of it is?
That hidden in plain sight was, awesome. If we could get that out more often, if we could, expand on that. We could have people come out and talk about it. We could have, different law enforcement agencies come out and talk about, the drugs, show them the drugs. People don't understand, if you have that Vicodin prescription in your medicine cabinet and you only take it, for 10 days and you still have 20 pills left, and then, 6 months down the road it's still there, and you're feeling pain or a family member's feeling pain, they're going to go to it because they don't know what it is. They have to be educated. They believe the doctors. They believe the nurse. So if someone else in the family's having pain, they give them the Vicodin. If Johnny's having a party and, one of his friends goes to the bathroom and opens a medicine cabinet and sees Vicodin, he knows that his brother likes Vicodin. It's a bad cycle, and that's how it happens. So I would get it out, just like that, hidden in plain sight.
Mr. Chair, if I could.
Can I add to that real quick?
Go ahead.
I think one of the approaches that we should take is similar to the pharmaceutical companies. And what I mean by that is they were very strategic about 5 to 7 years ago of implementing what they called the fifth vital sign, which was pain. That was recorded by any of the hospital administration centers when they came up for review. They were making sure that folks weren't discharged in pain. They were properly treated and given the proper prescription. That took hold pretty significantly, the fifth vital sign, and that wasn't anything that we grew up in the system. Pain wasn't it was okay to have a little bit of a pain. You break an arm, you have pain, it's just you need to deal with it. That took hold. I think if we take the approach like the pharmaceutical companies do, and I look, how do you access millions of people quickly? Everyone has a smartphone, and I can pull up, channel X news on my smartphone, and it'll tell me how to get Vicodin, where to get a prescription, and who to access to get that. I think if we leverage those marketing techniques of the pharmaceutical companies, it will be beneficial to impact the most lives that are out there.
Mr. Chair, if I could follow up on that. That's an interesting point because you brought up technology, and I think what we need to think about is a way to contact parents or access parents or educate parents locally using technology. We require parents, athletes' parents to go through a concussion training. We can utilize technology here to educate about opiates, some sort of requirement. But what you brought up about pain and pain being kind of subjective and patients not needing to be in pain, that's, I think, something we also have to train parents on, is that maybe it's okay to experience a little bit of pain because this whole issue resulted from the American Centers for Pain being very concerned with the liabilities of pain, which led to the creation of pharmaceutical opiate prescription painkillers even being developed, and then pushed to doctors and pushed down the throats of patients. So I think we also have to educate the public that a little bit of pain is okay, and it's okay to feel a little bit of discomfort. I know that we always shy away from that, and we think that's a scary thing to tell people, but I think we have to change our mindset before we do anything else. I just want to ask, from your professional standpoint, what are the guidelines that you fall under for HIPAA? What are you allowed to share interagency? What restrictions do you have on you as EMS professionals, as firefighters, related to HIPAA?
Interagency, it's not a problem because we're all associated with the same event. To produce any propaganda that would then go back to a household would get a little bit intricate, and what I mean by that is if it was an individual of legal age that had a medical condition and we shared that medical condition with their family. Example, I go into the hospital with a heart condition and I don't want my parents to know. I don't have to tell them, and the hospital doesn't have to release that information because I'm an adult. Why would this be different than that? It really wouldn't under our umbrella. So we would have to get under a different initiative for somebody non-medical to maybe identify that area to do it. And I think that's why you see a lot of these follow-ups being done by law enforcement. Boston Police, for example, Plymouth Police, Brockton, it seems to be under a different venue, which is outside of those HIPAA regulations and requirements.
And that's what I'm asking. And for the record, what I would like this committee to explore is the consideration of a town social worker. And the reason I say that is because communities are now turning to social workers that would work under the police department or the town, and a substance abuse coordinator, or under even the fire department. And what the social worker is allowed to do is they have a little more flexibility where they can take information from you and say, we've had this person that overdosed. You're protected under HIPAA. They're protected under HIPAA. They can take that information. They can visit that person, still be protected under HIPAA, and they have a little more knowledge of resources. They have a little more knowledge of the social effects of drug usage and everything that goes to it, and they can work with that person to get them some resources and get them into recovery. So I think if we're looking to follow up on people that have been overdosed, and also to better educate families of kids that have suffered from an overdose, or even preventatively, I think a social worker is a great avenue for us to explore. And whether that's under the fire department or police or as a substance abuse coordinator, I think it's a real void that could be filled.
That would have to be in coordination with some of the hospital staff as well. And what I mean by that is, in the field we do a little bit of shooting from the hip, based on a story, based on paraphernalia, based on the patient presentation. But we don't do talk screens, any labs in the field to say that, yes, this was indeed an opiate that caused it. So that final definition, or you would need a feeder to give you that information to say this is the category of patient that it may fit into.
Well, could I ask, with the social worker, you should be able to say, and that's why I think the social work piece is unique versus the medical side of things, because you should be, let's say you arrive to a home that's in squalor, right? A home that is in absolute disrepair and a hoarding situation. Maybe it's not drug related, but you as first responders are responding to a medical event there, see that person is probably in need of some services clinically. You could refer to a social worker and say, hey, we arrived at this home, or you would contact elder services or whoever it may be, because it's a social worker where you don't necessarily need definite information that you could report, and you're really reporting a concern that would later be explored. Is that true? I mean,
Well, we are mandated reporters in
Right.
certain areas, so I think it's a great idea, and I think, you should explore that. I think it would have a perfect fit here. There's other communities around us that have a social worker involved.
If I could add to that, we've come across recently some hoarding situations, elderly, and we've tried every department we can to reach out to them, Elder Affairs, Board of Health, Fire Department, Police. I'm not sure if a social worker would have any greater impact than we would. They're either going to let you in or they're not, and they're not obligated under any circumstance by the law to let anybody in. And that's what we've come across, literally sitting at the front door, not going to move out of their chair to allow us in there.
Yeah.
So I'm not sure if a social
I'll tell you,
worker
at this point, there was an initiative put together by the police in which we'll be able to discuss more tomorrow, in which they did have a follow-up. I mean, obviously, if the police go to an overdose and there's drug paraphernalia, et cetera, then they have cause to go to that place. But that's something that we can talk, more in length with the police department about, and we could talk about a social worker. I think in their capacity, they're able to save lives, and it seems, for the most part, we do want to get to Lieutenant Mackley's, but it seems that the education piece is, has been the piece that they've both been very vocal about, education, and they both have made somewhat of a commitment to be part of that education process, and I think it's great, and the ideas that you guys have come up with are great, and it's something that we could put as part of our report. But I think at this point, unless anyone has anything else to say right at this moment, I think we should let Lieutenant Mackley's just give that information update. Mr. Mackley's. Absolutely. Okay, no problem.
Okay, so the 2015 year-end demographics, there was 22 females, 57 males, 30 residents, 49 non-residents, and 5 deaths in the town of Braintree for 2015. For the first 3 months of 2016, we had 8 females, 19 males, 17 were residents, 6 were non-residents, 4 were unknown. There was 3 deaths.
Okay.
Lieutenant, in those 5 deaths, I think there's an update to that information, if I'm not mistaken. The information that you provided to Mopsy, you have a number of metrics or indexes that are being collected now, and we know it's early in the stage, but the number of deaths is tragic, but I think there's more than 5 right now, right? Aren't there 6 or 7?
There would be 8 total.
8 total.
15 months.
Okay, in 15 months.
Mm-hmm.
Thank you. Okay, so one of the things that we want to impress upon the public who's watching is that those 7 deaths or 8 deaths, above and beyond that, there were times 15 that were overdosed. So the overdosed number is the one that is, look, at anybody who dies is horrible. But there's some number that says we have been to 300 overdoses and 5 have died. What's that number of overdoses that you've responded to?
Okay, so let me just back up a second. I collect for the town of Braintree the Narcan deployment overdoses, okay? There might have been 300 overdoses in Braintree,
Yeah.
but I collect the Narcan deployed overdoses,
Only.
okay? So those numbers that you have, and that's what the MOPSI meeting was about.
Yeah.
Like I said, it was in 2015, it was 22 females and 57 males that overdosed and 5 deaths. In 2016, it was 8 females and 9 males, 7 residents, 6 non-residents, and 4 unknown in 2016. So that's all that I do for the MOPSI. So I take the police fire data, so when they go to a call and they utilize their Narcan, I compare my data with Chris's data to make sure that we didn't count the same trip sheet.
Sure.
Okay, and then I take off of his data if he did additional Narcan, that's where, in that MOPSI sheet that's still in a rough draft
Yeah.
format,
Yeah.
to make sure that we're not doubling up everything. So I sterilize it, and I present it to, once a month, to the board, the MOPSI.
All right. Thank you for clarifying that. But with that said, for the public's point of view, I think the number, death is horrible. But the number of times that the fire or EMS or the police have to respond is that higher number. And those are the numbers that we're saying, 300 calls based on this cost component, stressing your resources. Is there anything that we can do?
If you could, can you clarify that as far as, what you can do for us? I mean, as far as manpower or funding or?
Well, Chief, you come before us every year and you say, we need new people.
Can I interrupt for a second? So in 2014, February of 2014, the chief called me in his office and he said, we have this program, I want you to take the ball and run with it.
Yeah.
And it was the Narcan program.
Yeah.
And you guys gave us the tools for the toolbox. So we're running with it. Those, brothers and sister firefighters,
yeah,
they embraced it. Yeah. This is unfortunately, it's second nature to them. Just like 20 years ago when you guys gave us the defibrillators, they embraced it. We've knocked out sudden cardiac death. We had the most saves in the South Shore 20 years ago. They've embraced it. So we get it. We got it. It's getting it to the next level, moving on to the next ride. We have everything that we basically need. We have Narcan.
Well, for clarification on my end of it, we do not need more manpower. It's not stressing us as far as, our ranks go. As far as funding goes, I think what the mayor's doing, I think what he outlined in this letter is pretty clear to everybody. We're all on this. And if there is more funding out there and we can get it, all the more power to us. And you know how I feel where it should go, or most of it anyway.
Okay. So I guess just to kind of close that piece up, Chief, with you and your peers, when you meet, are there any particularly interesting best practices that some other towns of your peer group have instituted that you might want to adopt here in Braintree?
Every community is different. Some are larger, obviously, some are smaller. Some are richer, some are poorer. I don't think the opiate epidemic really has a demographic. I think that's crystal clear. You read the papers every day, you watch the news, it's in every community. Do we borrow ideas from each other? I think the system is pretty much universal. So we don't really communicate with other departments and say, we may talk and ask how many overdoses have you had? How many reversals have you had? But it's a pretty standard practice for every community, every fire department. I can't speak for the police department, but I can speak for the fire department. It's pretty standard.
Okay. Well, let me just close it off then with my last question. Brockton's introduced the Champion program, Chris, and I know it's only been introduced since February. Could you give a broad thumbnail sketch of that coalition between the police department and the fire department and the group that has the beds?
Sure. So the Champion program was an initiative by the mayor in Brockton for folks to self-present in order to get help. So in coordination with the Stairway to Recovery, in Brockton, a center. What they have is advocacy and services available when folks self-present and say that they need help. There's certain criteria which the mayor has worked out with local rehabs to accept these folks in when they self-present. So there's open beds they can go into, services. I'm not sure how those payment options work. If they're either state funded or city funded, I'm not sure how that funding works to support those folks. But that's essentially how the the coalition gets together. Folks self-present to the Stairway to Recovery, which is right next to the police department, so they can either walk into the police department or into the Stairway to Recovery, ask for help and assistance. They get an evaluation. It might be something as simple as, let's take your story, let's get you some information, some help that you need, and we're going to schedule folks to see you or visit you because of a behavioral health versus substance abuse piece. Or it may be you need to go to rehab immediately. So, they kind of relinquish, some of their paraphernalia that goes along with it. There's certain criteria to get into the program. Clearly, anybody that has warrants and things like that has to be ironed out ahead of time. But it's a direct avenue for recovery when you self-present as opposed to being forced through court services, Section 12s, Section 35s, things of that nature. The program has been a little bit slow to take off, but now that the word is out there, there are folks that visit it. And it's a tremendous opportunity. I don't want to say it's exactly like, but it's similar to the Gloucester program, where folks can self-present and get introduced for help.
And they get a bed immediately rather than having to wait.
I'm sorry?
And they get a bed immediately rather than having to wait.
Yeah, I don't know what the immediate availability is, but the amount of resources that the mayor has in that city, I think between the dedications of 1 or 2 beds, it may not just be an open room there. They'll make some room, they'll work something out, they'll get them into services, but it doesn't sound like they'll turn people away. If they have to go outside of the Brockton proper, they do have some networking in place through those rehabs to then, get them outside of the Brockton area, and they may have to travel a little bit to do so. But
Okay. Thank you, Chris.
Thank you, Counselor. Counselor, you were next. Yeah, next.
Thank
Counselor.
you, Mr. Chairman. A quick comment, Lieutenant McAleese, which you said, and I think it's worth restating, is both the fire and the police took on Narcan, trained, didn't collectively bargain it. It could have been, but it just showed both your departments' true commitment to this town and saving lives in this community, so I commend you for that. I think that's important for the people at home to know that you guys are 100% behind this. So kudos to all of you for that and bringing this years ago to it. 2 follow-up questions from earlier. So Narcan, you're basically getting it for free right now, the fire department, correct? Because of the one-on-one swap you mentioned. So what is the grant being used for, or is it being used right now?
It's not being used. The grant was the IM injectors of Narcan. It was a donation of so many devices to public safety, Board of Health, schools. So that was the initial grant. The grant or the program before that came out of the Norfolk County DA's office, where he supplied us all with initial doses.
Oh, you're right.
Supplied us with all the initial doses of Narcan to get the programs up and running. And then he did the train-the-trainer program for officers like myself and my counterpart, Lieutenant Viola, to get train-the-trainer so we could go back to our people and train them to the level that they needed to be at.
Okay, thank you. So right now, police, fire, and school nurses have Narcan in the community in terms of town departments and EMS as well. If another town department, say Elder Affairs, Parks and Rec, wanted Narcan and they were trained in it, do you see any reason why they should not have it? And if not, how can we get it to them? Can it be...
So there would have to be a meeting with the town's medical director, Dr. Nettleman, and probably the Board of Health, and would have to present the the equation to them and figure it out to see if there was a need for it.
Okay.
Okay.
And one last question. Chris, you had mentioned about forecasting, what you would like to do in the future. Given the data that you're all collecting now, is that something we could do? I mean, it seems like you're already collecting that data right now, and I know when the police were before the town council, I forget the officer who was here speaking, but basically he said he could track it into the town where the overdoses were, or was it you? I'm sorry.
It was me.
Oh, sorry. Okay.
That's okay.
So we could be
Police, fire.
doing that right now. It's just more reports that have to be created. Is that correct?
Not necessarily. We can do reports in retrospect. Medical intelligence is a very hot topic right now, along with police intelligence, and using some forms of artificial intelligence. And I'm not saying planting chips in anybody's heads or anything like that, but there are different tracking programs that are out there that, based on historical data of response within the towns, that will tell you on Thursday night at 9 o'clock in this area of the town, there is a probability of an EMS call, which may be overdose in relation. This moving map kind of, it looks like a weather forecast that moves over the community. And how do I put this? We know that after game day of Red Sox that you're going to get a call off the red line sometime after the game, right? So we know that. We pre-position assets down there. We know a place is going to be crazy. What this does is it takes the guesswork out of it, of being that local knowledge, and it tells you based on historical data. You'll see this moving map that just continually moves over Braintree or the community, Braintree, Weymouth, Quincy, to say you need to start concentrating your resources in this area. So medical intelligence and law enforcement intelligence is a hot topic now, but it's based on retrospective data that pinpoints time, place, location, and what to expect. If that call doesn't happen, it doesn't happen, but the probability that it will is pretty spot on. So that's going to be a hot topic over the next quarter with us. We're looking into that technology as we speak, but it's something that I think you'll see come on the horizon. It's pretty interesting to watch. Another piece of technology that's out there is called the FIRST. I may get this wrong. I believe it's a FIRST watch system. It was designed for epidemics through the CDC to cover epidemics and flu epidemics that are throughout the country. And what they are is it reports into a national database, so you can see numbers increase and fluctuate on probability in areas. Now, the First Watch system is available to local government providers. I don't know if it's free if you feed into the CDC system. I don't think that anything's free with those folks, but it may be worth a look.
Thank you.
So if I could just add to that. So in 2015, if you remember from my last time here, when I tracked the days, it was Tuesdays, Thursdays, and Fridays that we had the most overdoses in the town of Braintree. So kind of gives you an idea of what we can predict going forward.
Excellent. Council Powers, then Council Owens.
Chairman, Lieutenant McAleese, you said in 2015 there were roughly 300 overdoses in the town? Is that, I'm sorry, 300 cases? 300 total cases?
Yeah, so the report that was run under the data that we can pull is poisoning, drug ingestion, or substance and drug abuse. Those are how it gets populated.
And that's 300 for the calendar year of 2015?
That was 227 unit responses for that.
For 2015?
For 2015 into early 2000 to date. So the entire 2015 to April 19th when the data was run.
Okay. Is there ever, so my question is that if someone overdoses and they're driven to the hospital by their friends, that's not going to show up in that data, is it?
No, it's not. It's not.
So there actually could be more overdoses that we don't know about.
Right. There could be more overdoses that happen in the home that are reversed with Narcan and they stay with their friends with a cold shower and a bag of Doritos.
Mm-hmm. Nice. And you said that there were 49 non-resident overdoses?
Yes.
In 2015 or 2015 to date today?
That would be 2015, not to date, 2015.
Just calendar year 2049, and then the residential number was?
Um,
I'm sorry, I don't have the chart in front of me. I apologize.
30.
30, so there's more non-residents than residents
Yes.
in 2015. Obviously, when we're responding to more calls, the call volume for all three of our public safety is going to increase, correct? If we're responding to calls of overdoses for police, fire, and EMS. That obviously has to be somewhat of a concern. If we're seeing a call volume, that means if a fire truck or a paramedic truck is responding to an overdose, and something else happens at the same time, then there could be a strain on the resources, correct?
You're correct in saying that, but we're not biased as to what call comes in for service.
Sure. No, I wasn't implying that, but I'm saying that is if we're seeing more and more cases of overdoses on the rise, the overall volume of calls to our public safety departments is increasing. Would you agree?
That's correct.
Okay. So that's obviously something. And then if we're able to quantify that cost of the increases in calls every time we have to send out a fire truck, because there is a constant increase in overdose calls, it starts to become a strain. Not now, but I mean at some point, overall, if you look at the overall arc of a year from January 1 to December 31st, and there's an increase in volume and the amount of runs that our public and calls that our public safety departments are going to, that's a concern. So, thank you, Mr. Chairman.
Thank you. Council Owens?
Thank you, Mr. Chairman. So when if somebody were to call any one of you or the department and say, my son overdosed, what can I do to help him? Who do you call? Who do you refer that person to?
So there are a number of advocacy agencies that are out there, either through Manette Health Centers, community health centers, Learn to Cope, which is a local program, where folks will get together with the families, point them in the right directions for the help they need. That may be medical help, it may be legal help, it may just be behavioral help, not only on the patient end, but on the family end. There's a lot of money that families are putting out for rehabilitation services. There's a lot of theft that occurs in the home. Or there's a lot of money distributed from parents to children, not necessarily to support their habit, but to pay for other bills that kind of come along. So the Learn to Cope folks, as well as Manette and other community programs, are available. We probably point them towards that.
In terms of a bed, if somebody says, if I call you and I say I need to get my son into a rehab or a facility, what would you say? Would you say go to the courthouse, do a Section 35? I'm just curious, if we're talking about follow-up care, what is the current protocol if somebody asks you personally or professionally, whether you know the person or don't? Is there, for any one of you, is there a particular avenue? Would you say Gavin Foundation? Would you say court? Would you say, what does that look like today?
I think it depends on the individual circumstance. If it's voluntary versus involuntary, some of the folks for rehab require a medical clearance prior to getting into the rehab to make sure that there's not an underlying medical condition and they're clear to go through, that phase of recovery. So it would have to be case dependent. And I'm sorry that doesn't answer your question.
No, and I think you're right. I mean, everyone's situation is different, but I think that's something that this committee should seriously look at is, a venue or a number of resources that we are verifying that we can refer to. I mean, obviously Section 35 is unwilling. Gavin Foundation has resources for people that are willing and, that could get there unwillingly as well. But, there's resources, but I think we have to, as a town, know what we're referring and to whom.
We've had a few instances, I'd say 6 or 7 so far, where individuals have walked into the fire station, into fire alarm seeking help, and we've called the Gavin Foundation, and they've been out there within 15 minutes.
Yeah.
I mean, they're unbelievable.
They are.
So the help is out there. So when you ask that question, I mean, that's kind of our go-to foundation. That's our go-to people.
Right?
Yeah, they're great.
Right. I have a question specifically about overdoses. Vivitrol, which I'm sure you're all familiar with, for those at home that may not be familiar, is currently being prescribed as a drug to get people off of opiate addiction, and it's basically a blocker of opiates. And because it's a blocker, what I've heard, what I've seen a little bit of, is that people on Vivitrol, if they relapse and begin using again, because they're on Vivitrol, it's blocking the substance, so they're not getting the full effect. So they're taking, if they pick up heroin again, let's say, they're using an excessive amount of that, and they can't feel the effect, so it kind of exacerbates an overdose. Have you seen any of those cases where Vivitrol is being taken by prescription to somebody that is overdosed? I mean, have you seen the relation there? So in other words, what I'm saying is Vivitrol obviously is a blocker of opiates, and what I've heard is that people that are being prescribed Vivitrol, because it's a blocker, if the person relapses, it's blocking the effect, so they're not feeling the effect, so they're taking more of the substance to get them high because they're not feeling it, which is obviously increasing the effect of an overdose or rapid, causing to move faster, I guess. Is there?
Yeah, to answer your question, we have not seen a pattern of that develop as of yet.
And do any of you collect data? Do any of your departments or police that we know of collect data on? I know we do a lot of overdose data and a lot of substance abuse data, but do we do any data on people that are in our community currently taking by prescription Suboxone, Vivitrol, OxyContin, oxycodone, Vicodin, and are we even allowed to collect that data?
We collect that data on the ambulance end.
And
Not on the pre-hospital end, on our end, first responder end. We do not.
okay, is legally, can you share that with the, say, the Department of Public Health? How many people in our community have had contact with an ambulance that have been are taking prescription Suboxone, Vivitrol, OxyContin, oxycodone, etc.?
We could run that data as long as it doesn't have a patient attachment to it.
I'd be very interested in seeing that data, because that really tells us how many people are functioning on opiates, whether that's before they have an addiction and they're being prescribed pain medication regularly for their daily life, or after an addiction, obviously Suboxone and Vivitrol, how many people are in aftercare. So I'd be very interested in seeing those numbers for Braintree. Thank you, Mr. Chairman.
I think overall, the message is pretty clear that education would be significant. And what I would ask is that you put together some of the stuff we've talked about, and what, and kind of put together the things that are most important to you as firefighters, as emergency response, EMTs, for us to put together with our report. I mean, we've talked about a lot of things here, but if there's something that we might not have talked about that's important, if you can put that together. Obviously, as far as funding sources go, we know it costs money to put in programs for education, et cetera. That's something we'll deal with, but I think that any other information that you can provide to us, and we'll have an ongoing relationship, Lieutenant McAleese and I will, in regards to the statistical data, and we'll keep folks updated at council meetings on that. We do have some folks in the audience, and I know that we have Mr. Thompson, who's here, who would just like to speak, and if you'd like to go up to the microphone.
Thank you, sir.
Yes.
Yes, sir.
Chief, you spoke about early education, so can you provide us some more beef behind that when you leave here?
Absolutely.
Thank you. And as far as the cost model goes, could you provide us this is a simple call that comes into our office. The call comes in, it gets dispatched, these many resources are sent out. On average, it's a 2-hour call, a half-an-hour call, and whatever those cost components are around that, can you provide that?
That would be a medical, not a fire.
Right. Well, I mean, I can tell you right now that the costs associated with each run, there's really no gauge for that. I mean, we have a manning clause that, if you wanted to take the overall budget, that it costs to have 21 men per shift and a minimum manning.
No. I don't mean that. I mean just narrowly focused on.
That's the way you have to do it, Counselor. There's really there's no cost per run that I've ever heard of. Have you ever heard of that?
No.
Well,
I could work
let me
with
ask this.
them. I could work with them on that.
Usage and mileage.
Let me just
and
ask
wear
this,
and tear, I
okay?
mean, it's-
For any opiate call or any overdose call, you know that X number of guys go out, police, whatever their rate is that they go out there, the reporting, you know, whatever cost components goes into an average call, that's...
If you can provide that data, if you can put it together. then
Okay, I'll see if
we'll
I can
talk
break
about
it down
Okay.
a little bit further than, you know, what I have, but it's
I don't, Chief, honest to God, I don't mean to go into the bowels of it, but just to say, hey, we get a call, we dispatch 2 guys, the average cost of that dispatch is X, he's out for 2 hours, the report gets written, you know, this is not rocket science. I'm not asking you to boil the ocean. Just a thumbnail sketch of what it might cost per call.
I'll do my best.
Appreciate it.
Okay. Mr. Thompson, thank you for waiting. Thank you for coming tonight.
I appreciate it. I did not come here to talk tonight. I just kind of heard about it a few minutes ago. Unfortunately, I've been involved in this for about 6 years now. And Braintree is lagging behind a lot of towns in their approach to opiates, heroin, drinking, alcohol. We tend to, unfortunately, high school kids, you know, you look the other way sometimes and we do this and that. Alcohol is the launch pad to drugs. They don't start at heroin and end at alcohol. They start at alcohol and end at heroin. And that's just how it goes. We, the fire department, my son's a fireman in Boston. I hear stories that would make your toes curl and make you cry. He tells me stories. He watched his brother die, my son. He went to Iraq. He watched a bunch of more people die. And he comes here and he sees kids dying, kids, young adults. And the unfortunate thing about it is these guys, you asked them that question, what can we help you more with? You can help them by not giving them more money. You can give them better educated kids. We can have our leaders lead, have our educators educate, and do their job. Because my wife and I 6 years ago went and we came to the town and we said, you know, we're going to raise some money and we'll sponsor your awareness program. We've raised hundreds of thousands of dollars and Braintree's taken probably a few $1,000. It was all theirs. No strings. Get who you want. They brought Chris Heron in. Geez, I said, come on, we'll bring him back. No, we heard him once. I don't care if the teachers heard him once. I want the kids to hear him. I want them to understand. I begged them. I dragged them to Quincy. $200,000, tax-free, handed to you, no strings attached, nothing. Nobody reached out. Nobody said, hey, that's a good idea. First, we had a superintendent that was retiring. Then we had one that should have retired. And now we have a new one, and he's getting his feet wet. I'm tired of people getting their feet wet. 2,000 kids that they know have died in this state this year. 2,000, not 2. If one kid fell off a school bus, they'd have a state of emergency here. 2,000 that they know about. You asked the question a little while ago. It was last week in a meeting. What streets do we have to worry about? What houses? Every single street and every single house in this town knows someone, has someone, cares about someone. These guys are left out there hanging by their teeth. They show up, they knock at them. That's the finish line. You guys got to start in the beginning. You're at the finish line. Get away from the finish line. Go to the beginning and educate. Educate. Ignorance is, we go around, so my wife and I and my friends, we raise money. We give them to the youth groups. We bring the Gavin House, the Serenity House. They come in, we sat here with the young Babe Ruth group. 2 of the kids came forward. They were already in trouble because we just came in and chatted. That's all we did. We didn't step over the boundaries. We want to educate kindergarten parents, elementary school parents. We want to get the kids in junior high. We want mentoring programs. We want kids helping kids. You guys, everyone cares, but there's not. We're in our village. You're asking questions about, well, are they from out of state or are they in state? Does that matter? Does it matter? They're dead. They're dead. My son died in California. He didn't die in Braintree, so it doesn't count in Braintree. I could give you 25 more kids that have died from Braintree, but they didn't die in Braintree. So it don't count. Does it count? Yeah, it counts. It counts. It counts big time. We need police. I watched a school committee meeting one night, and I watched the police get beaten up because a bunch of kids got caught drinking, and they were the wrong kids because they were nice kids. I don't care. Zero tolerance. Zero. Zero. Oh, my kid, it was by accident they were there. Okay, well then they can't play sports. There's rules. It's not the rules because we want to catch the bad kid. We want to save everyone here. This is a net. You guys, I watched that meeting that night. I was embarrassed. It was embarrassing to watch it. I'm watching the parents scream at him. The cops getting yelled at. And I'm thinking to myself, if I'm a cop, where do we go from here? Oh, geez, we'll look at changing the rules. Oh, we'll look at the rule. No, we won't look at changing the rules. Zero tolerance. Zero. So you win a state championship, but 2 of those kids of the team died from a drug overdose. So what's more important, the state championship or the 2 dead kids? Which one? Tell me which one. Is it the dead kids or is it the state championship? So I could sit in a bar room 30 years from now and tell everyone, I want a state championship. I'm a booze bag and I take pills, but I want a state championship. Who cares? Sports are great. It's fun. It is. It's awesome. I went to a sports thing. Mr. Owens right here did a fine job. They ran it, and they were talking about kids getting hurt, not prescribing, going to the doctors, don't prescribe. And I'm sitting there listening, and there was, I think they said 164 coaches in Braintree. How many people talk about drugs in Braintree in schools? 0. 164 coaches. 164. 0 talked about drugs. You want to get real? Get real. Braintree's hiding. Their eyes are closed. Well, maybe it'll go away. It's not going away. It's getting worse and worse. My son's dead. I can't bring him back, but I promised him that I would do something about him. I don't want him to die because he was a great kid. He made a mistake. He was ignorant. He didn't know. Do you know the higher percentage of children that die from overdoses tend to have ADD or some form of ADD or some... Does anyone talk about that? Nope. Well, we got 164 sports coaches. 164. So we can talk about baseball and we can talk about this and that. There's an approach here that's gone down the wrong runway. You don't win. Not every kid gets a silver star on his forehead. When you get out of college, get a job. No more silver star kid. Get a job. Let's go. So I'm not yelling at you, but I know what they do. And you guys are throwing these questions at them. They go out, they run out, there's pouring rain, they find a kid, they knock in him, they wake him up, guess where he's going? Back to do heroin. My kid did 3 times one night, same shift, knock in him 3 times. 3 times. You know how many parents? A parent called me yesterday. I get calls my son died. They think I'm an expert. I'm not an expert. I'm an idiot. I didn't know I was ignorant because I wasn't educated and I didn't know. Ignorant doesn't mean I'm stupid. It just means I wasn't told. You guys lead. You're leaders. You're the leader. You're a leader. You're all leaders. Lead. Lead. Don't say the state, we're going to follow the state. 2,000 kids died. Those idiots in the state of saying, well, we're going to do another survey and tell you how many died. They're dead. They're dead. This isn't in a book. You can't read it. You can't read it. It's different. Sometimes you just got to go out and do stuff. Do stuff. Educate them. Tell a parent of a kindergarten kid, hey, get the medicine out of your cabinet. It shouldn't be there. 1 pill. My son said to me, he was so honest with me, Dad, I took 1 Oxycontin, I couldn't wait to take the next one. He sucked them in. Sucked them in. Don't let it suck you in. Don't get sucked in. Be a leader. You guys are leaders. We'll follow you if you lead us, but you're not leading us right now. Lead us, please. Please lead us. Please go to school. $200,000. No, we don't want it. We don't want free money. We got other shit to do. We had stuff to do. That's wrong. It's wrong. It's wrong. I'm not yelling at you guys. I'm yelling at myself. I'm yelling, trying to tell everyone it's happening. Every one of you up there knows someone, and if you tell me you don't, you're a liar. You know someone, you know someone, you know someone. You all know someone, and I know someone. I got a phone call yesterday. A guy says, a friend of mine, his son's in Florida with a mother that divorced, blah, blah, blah. He did this, he overdosed. And he's talking, what do I do? The kid's 17, no, 16. I said, what did you do? And we're talking about it. They knocked in and did this. And I go, they divorced bad parents. I said, tell this guy either to get on an airplane right now or get an ironing board out and start ironing a suit, or he's going to a funeral. You got to be a father. We need police, we need leaders, we need parents, we need police, we need firemen. We don't need bullshit. All right? And we can all talk about it. How long have we talked about it? 6 years? No dogs. Dogs ain't bad, but if you don't want to do it, okay, don't do it. But don't say, we did Narcan. Oh, that's great. You're at the finish line. Those people are about to die. They're this close. They saved their lives. They saved their lives. You ask how many kids in this town were from out of town? 30. How many of our kids from Braintree in another town? Who cares? They're dead. They're dying. And do you know what it's like to have a child that's just, you look at him in the eyes and there's nothing there. They're pinned to the back of his head and they're crying. I laid in bed with him. He's crying, bawling, crying. Crying. It owns you. Dad, it's my best friend. It's my best friend. It's called ignorance. Ignorance. So in closing here, I'm not mad at you guys. Not mad at you guys at all. Not mad at all. But be a leader. If you want to get elected and you want to be all this stuff, lead. If you don't, leave. Go somewhere else. Go do something else. It's okay. I'm not mad at any one of you. I'm not mad at none of you. It upsets me that my wife and I and all my friends raise a couple $100,000 and Braintree goes, nah, no big deal. Nah, nah. Maybe next year. That's what I remember I went to SAD group. We do the Quincy program. Spectacular. Spectacular. Incredible. You'd cry if you went over there. They do a job. They got kids that live on the streets that are homeless kids going to the high school in the SAD program. How many homeless kids are in Braintree? Do you know any? Do you know any? We're in Wonderland here. Braintree's beautiful. It's a great town. But open your eyes. Open your eyes and lead. Michael, lead. Lead. Please lead. Lead us. We'll follow you. I'm not yelling. I'm not screaming. I'm speaking from experience. I watched my son die, and it's not the funnest thing in the world to do. And every night I lay in bed thinking, it's my fault. It's my fault because I'm the captain of the ship. I'm the captain. That's me. It's my fault. And then you look around and I go, I was a great parent. I did more crap in this town than long before this, and I don't need to be patted in the back. But I don't want it to happen to you, or you, or you, or you, or you. If it happens to your kid, wait till you see what happens. You'll see tears. You'll see change. Don't let it happen to you, and you, and you, and you, and you, and you. Lead us. Don't prod us. Lead us. Show us. Show our kids. Leave it better than you found. Leave it better than you found it. If you do that, we're better for it. Thank you.
Thank you, Peter. Thank you, Peter.
Not at all.
Thank you.
Would anyone else like to speak?
Is there anyone else in the audience who would like to speak?
Just two things. Peter, I know your passion, I know your sadness. I'm not going to go there tonight because I know we're trying to deal with the fire and EMS. So I just had a question. I know Weymouth had an issue with one of their fire department employees who was vocalizing his distress over the number, reporting to the same person, overdosing a number of times. I didn't know if Braintree had some type of stress program for your employees to deal with this so that they look at these people as humans with a medical problem and don't look down at them. Nobody wants to be an addict. Nobody grows up and says, I want to be an addict. They may overdose 9, 10 times. They still deserve another chance, and they deserve every single time to be looked at as someone's child. So I just wanted to know about that. And then while I have the floor, because I only want to say one other thing. You said, where can people go for help? Massachusetts has a program. As Massachusetts residents, it's free. Other states have to pay for it. So you put your zip code in, and it becomes a free program. It's called Allies in Recovery. And you just go to alliesinrecovery.net. It has a wealth of resources. It has family support. It's where you can get help for your loved one and how to cope. And again, it's free. So everybody should know about it, and it's not widely publicized.
Thank you. Chief?
To answer your question, we have the EAP, which is the Employee Assistance Program, and if any of our employees are having difficulty dealing with any aspect of the job, we encourage them to seek help through the EAP.
Excellent. I think that, your leadership and Lieutenant McAleese's leadership, trickles down throughout the entire department, and I appreciate that.
Thank you.
Is there any further comments? Okay. I appreciate everybody coming out tonight, and, this is, obviously we had fire and EMS tonight, but, the way that, I think that these meetings should go is that if members of the public come and they want to speak and educate the public on this epidemic, we want participation. So I appreciate the participation by all members of the public, and we love you, Peter. You're part of the family, and we're hoping that we can lead, and that's our goal. Our next meeting will be tomorrow night, and that will be with the Braintree Police. And there's no more comments. I would entertain a motion to adjourn. Motion's made and seconded. Any discussion? Hearing none. All those in favor say aye. Aye. Opposed? We are adjourned. Thank you.